most excited about in this year or the next 2 years, let's say, in things moving along with multiple sclerosis that you're finding that are coming up?
Well, the treat MS and deliver MS studies, I certainly like to see the results, although I feel I know what the results are going to be in advance. In terms of new products, I would say I'm most interested in two major classes of medications. One is the ATA 188 study, which is an immunotherapy against Epstein-Barr virus. And there's an ongoing study called the EMBOLD study, which is a randomized trial treatment versus placebo in progressive MS. I think that's a really new, innovative treatment like nothing we've ever seen before. I don't know for sure it will actually work in multiple sclerosis, but if it did, it would be truly great and maybe offer an effective treatment to people who aren't good candidates for immunosuppressive drugs. And it has implications for other Epstein-Barr virus related diseases like lymphoproliferative disorder after transplant or Epstein-Barr virus related cancers such as Burkitt's lymphoma. Now, we probably won't get a result by the end of 2023, but maybe we'll get some preliminary interim result. I don't know.
Yeah.
The other class of medications I'm really interested in is the Bruton's tyrosine kinase inhibitors. These are medications that are different from drugs such as Ocrevus, rituximab, and Kesimpta, in that they don't kill the B cells, but they influence the activity of the B cells.
Okay.
And so they're probably safer in older people with progressive MS. They're probably less likely to cause infections.
Okay.
And, one thing about progressive MS is there's some evidence that some of the progression may have nothing to do with these types of cells, the B and T cells, the lymphocytes. They may actually have to do with a slow sort of smoldering inflammation invisible on conventional MRI within the central nervous system. And so some people, they have this frustration where their doctor is telling them your MRI looks stable, but they just know they're slightly worse over the years. It may be due to a different type of inflammation.
Talk to me a little bit about, we've heard a lot last year about smoldering. And so I get a lot of questions about what does this mean? What's happening in my brain? I think some of it, I want to say the beginning of what I heard was when doctors were doing autopsies and they were finding activity underneath. Am I correct? Or am I mixing this? Am I mixing studies together? That could happen. I don't know.
Well, the general phenomenon that we see, the sort of clinical phenomenon, is that people often have progression related to pre-existing deficits. So let's say someone has transverse myelitis and they have a lesion on the right side of their cervical spine and they have weakness and numbness on the right side, but maybe they recover and they're doing pretty well and just have a little bit of residual numbness. Let's say that person is a 30-year-old newly diagnosed with MS. Sometimes, unfortunately, 30 years later, now the person is 60 years old, they may be on disease modifying therapy. They may be stable in terms of no new relapses or no new MRI lesions, but they're getting worse. They're noticing more weakness and numbness on the right side. And, even though there isn't a very strong correlation between lesions and disability, there is definitely this phenomenon where we see that people tend to have progression, a slow, insidious worsening in areas of prior central nervous system injury. Even in people with primary progressive multiple sclerosis, sometimes the disability correlates very well with what we see on MRI, even if they didn't have a known relapse associated with that lesion. So what is happening? Obviously, there's something happening within that lesion that is causing function to get worse. Well, there are a lot of different hypotheses. One could be that the damage to the myelin sort of predisposes the nervous system to accelerated aging later on. Maybe a young, healthy nervous system is able to compensate for that injury, get information through those nerve fibers, but maybe later on there's an energy failure of the cells. The mitochondria are not functioning as well. This is the idea of Minding My Mitochondria, the book by Dr. Terry Walls, and there's some evidence for this idea. Maybe there's some degeneration. Maybe the initial disease is more inflammatory, and later on it's more of a degenerative process, kind of similar to Parkinson's disease or Alzheimer's disease, where you're just losing nerve fibers. And we don't really have any drugs that prevent degeneration, even if we stop the inflammation. So those would be the sort of more pessimistic views, that this is
Right.
going to be harder to treat. But the
Mhm.
more optimistic view is it's still an inflammatory disease. It's just the
Mhm.
inflammation is of a different type that's
Mhm.
behind a closed blood-brain barrier. So if I
Right.
give you Limtrada and I kill your lymphocytes in your blood and your bone marrow, it doesn't matter, because those microglia and those macrophages are already in your spinal cord. They're sitting there. The drug doesn't get there. It doesn't act on those cells anyway. But maybe if we find this new target, we can intervene on it. So that's sort of the
Right.
optimistic view, that progressive multiple sclerosis is still an inflammatory disease. How do
Yes.
we know that? Well, we know based on autopsy studies that
Mhm.
we can see those cells within lesions that seem to have some activity. And more recently, on certain types of multimodal imaging, very specialized PET scans, we can see signs of this innate immune system inflammation. Now, obviously, an autopsy is not going to help, someone right now. And,
Right.
frankly, even these multimodal imaging studies aren't going to actually help an individual person with MS, but they'll help us understand that this drug could be effective. But,
Right.
just like with the elezanumab, we have to do the clinical trial to find out if it actually
Sure.
works.